It is a huge honor today to be with a idol of mine for decades. You're the lead. When I think of the lead prosthodontist at Buffalo, the lead prosthodontist at Ivoclar, for 30 years, I think of you. You've been teaching me prosthodontic information for 3 decades, and so thank you for that.
Well, thank you.
So first of all, I want to start off with, seriously, 28 years ago, my 3 uncles, not one of them had a tooth in their head when they got out of high school. Growing up in Parsons, Kansas, if you just waited till it hurt, and when you took them to the dentist, they pulled it. And so they all 3 lost all their teeth before they got out of high school. And when I got out of school in '87, I thought those days were just disappearing rapidly. And I thought, if you had asked me when I was 24 and walked out of school to today, I would have guessed dentures would be gone.
I agree.
And my God, they're still growing and growing and growing and growing and growing. Some of it's poverty, some of it's, the world's a big place. 7 billion people, only 1 billion people kind of live like us. And 3 billion people live off $3 a day. And they're told not to drink the well water because it's got cholera in it, they might die. So their leaders are telling them to drink soda, because soda might have cavities rot your teeth and make you fat, obese, and diabetic, but you're not going to die. And so are you surprised that dentures are still going strong 30 years? How long have you been a prosthodontist?
I was going to say your kind words were probably because I've been one of the more survivors of dentistry, been around for quite a long time. 40 plus years in dentistry.
40 years, and you're still better looking and have more hair than me. Is that because, maybe I should, if I would have been a prosthodontist, would I have had more hair than a general dentist?
Which was that easy. I enjoyed your comments, though, and again, thank you for the comments, kind words, and certainly my privilege and honor to be working with you and talking to you at this moment. The demographics of the patients have changed, and kind of somewhat unexpected by me personally as well. If I look back 20, 30 years ago, I would have thought removable was going to be a thing of the past in the near future. Certainly by now, I thought it would be disseminated, but a lot of contributing factors that I personally wasn't aware of. We're living longer, which is obviously a good thing. We're tipping the scales with the elderly in our demographic population. So I can't think of the statistics, but in 1900, maybe 4% of the population was over age 65. Now I think we're projected around 22 to 24% of the population over 65. So if you think of the numbers, you've got a large, we live longer, so there's a lot of people over the age of 65, and now the population growth on top of that. So we have a significant bubble of population over age 65. So all the preventive dentistry in the world catches up to individuals through disease or whatever it might be. Still at a certain age, you're going to be more prone to tooth loss, like it or not. But we're going to live longer, and we're enjoying good life, and it kind of brings up the kind of the interesting individuals that we're looking at that are quite different than they were. The removable patient, I think we stereotype in our mind someone who didn't take care of their teeth and they're not really interested in looking good or feeling well because they lost their teeth in the first place anyway. That stereotype sometimes still resounds, but it's somewhat unfair because what I've seen in our denture population is a very, very concerned group of individuals that are looking to us as professionals to provide them care that will make them certainly look better, look as good as they can, to function. They want to stay in society. They want to go to a favorite restaurant, and so a rather demanding group of individuals that are well read, well informed, and know the right questions to ask, and they're seeking better care. And it's kind of incumbent upon us as professionals to learn more, and so we can provide that level of care. So it is a significant shift. The numbers are there. We got 30 plus million patients who are already edentulated.
In the United States.
In the United States.
30 million.
And those are the same individuals who are starting to seek, implant treatment, which brings them back to the dentist to have that type of, which isn't really remaking of a denture. They're concerned about aesthetics and et cetera, brings them into the office more because the loss of vertical and things, they want to reestablish their appearance. And so that 30 million not only are already edentulated, but they're seeking care at a more rapid rate than they used to. My grandfather type of individual would have been satisfied with the same denture till they pass away. Whereas individuals now understand the importance of replacing a prosthesis to maintain their facial characteristics and things. So it's an educated patient for the most part that I think brings them back to the office more often, and then again, just pure numbers. The removable has not gone away. I represent a company that makes denture teeth, and we've seen a significant growth in denture tooth sales. I don't think it's all from other companies. Maybe we are doing quite well, but I think there is a significant growth in the removable market, which we're seeing in the way of sales.
Well, one of the things that you've been a big part of, and or your company, Ivoclar, is when I got out of school, coffee was free. I mean, in Kansas, you can get a cup of coffee at any gas station, and there's a pot of coffee, a little styrofoam cup, maybe. I never paid a penny for coffee, and I thought coffee was just cheap and free.
Yeah.
And then a man from Starbucks came out and said, you know what, coffee is no cost, it's free anywhere in Kansas at any diner or any gas station. But there is a market for people that will pay $5 for a chocolate mocha, something, whatever, and Starbucks. I was actually shocked when I saw Starbucks. I didn't see it coming. I didn't think that someday people pay $5 for a cup of coffee. And I think when I was in dental school, denture teeth were just cheap, chromatic, white. It was all low cost. It was just acrylic teeth, simple. And now you've kind of been part of saying, well, there's room for a Mercedes-Benz, Ferrari, Audi teeth. And we're sitting right here behind. Talk about the Blue Line and the Veneris. And I would reckon out of the 5,000 people that will be watching this, I bet maybe half of them don't know about it. So tell the evolution as a prosthodontist for 40 years, how Blue Line came about, and then after Blue Line, why Veneris? Why did you need two fancy teeth?
Well, the Blue Line was a kind of a gathering of information on the North American sector in particular. I kind of look at the Blue Line tooth as the ideal denture system for a dental school, and it was our target was to kind of Americanize the way the teeth are selected and the occlusal schemes to be more acceptable to the North American dental schools. So Blue Line was a kind of an experiment in a sense of tooth organization, occlusal schemes that we felt would be more popular, and it was very successful for us. It remains to be very successful. It's a tooth form that's chemistry-wise, it's a double cross-linked acrylic. It's on par with a premium polymethyl based denture tooth as far as we can go with that particular chemistry. So it's got the wear resistance, the aesthetics, about all we could have really achieved with the PMMA chemistry. The Veneris was a next in line, and I think we released that about 3 or 4 years ago, and that's a composite resin tooth. And major difference in tooth chemistry, the wear characteristic and especially the aesthetics are far different than a polymethyl based chemistry. As you know, in composite resins, we do this all the time in restorative dentistry, and the appearance is obviously quite good. And it has a nice chameleon effect and blends in with the other teeth and et cetera. And the Veneris teeth and that chemistry is very, very similar, based on the same as the restorative chemistry. So the aesthetics far exceeds what we're able to achieve with the polymethylmethacrylate. The intrinsic shading of the teeth so that it just bounces and it just pops at you when you look at it in the patient's mouth. Quite a bit different than your traditional denture tooth. Again, that was in a response. Not that's going to be for everybody or will be a demand for every individual, but for those patients looking to have a demanding to have a better quality denture tooth, something looks more natural. I think the Venaris is a great response, great response to their demand, and to have that degree of development. And I don't know if it'll stop there. I'd like to think we could constantly improve. Again, constantly trying to meet the demands of the patient. We've done that in all ceramic. That's been such a talked about, and again, it's patient demand. They're looking to have the veneers and whatever it might be to dentistry is becoming somewhat elective in that regard as far as aesthetic dentistry, and they're looking for a higher quality material, and the same for our movable patients. I'm going to correct myself just a wee bit. If I had a look at the big picture, we got certainly patients looking to have an improved performance and aesthetics and et cetera. And you kind of alluded to the coffee, and there's some will pay $5 and some are still looking for the nickel coffee, and of course we have a population of patients that may not, maybe they desire but they can't certainly afford that level of care that might be where somebody else is able to. So we certainly have that population of edentialism that probably needs to be serviced as well, and we have to be somewhat innovative in that end of the spectrum as well to provide good quality service, but at a I'm not sure how to put it, but at a discount technique, so that we're still able to provide good care for a lot of people that may still need those types of services. So it's quite a diverse population. That group is growing as well. I think with the influx of immigration, kind of touched on that a little bit, and et cetera, that a lot of these individuals, from third worlds and whatever, are coming into the States, and they are going to require dentistry that we thought we were maybe a little.
So you're saying the blue line was a PMMA, a polymethylmethacrylate, and that kind of maxed out the properties of that. Then you're saying the Venaris, which I think phonetics was kind of a resin composite, like a helium-molar tetric ceramic, more resin based.
Right.
Will the next generation be porcelain, like an Emax, or? And back in the day, there was porcelain teeth.
Right.
30 years ago. Right. So talk about porcelain teeth.
Well, we are probably one of the few manufacturers that do have a complete line of porcelain teeth as well. That's part of our cannular tooth setup. So we have a pretty significant tooth portfolio that even covers porcelain teeth. Porcelain teeth are probably the least popular tooth chemistry. They're beautiful teeth, but there's a bonding issue. They got to be held in mechanically. So there's some undesirable characteristic to the porcelain tooth that has, and they're difficult to adjust and et cetera. So probably. Is
it the clacking too?
If the vertical is impinged upon or whatever, patients may experience, the sound that they find distasteful. So there's some patient negatives.
We'll talk about that, because you're a prosthodontist, and so if they're clacking their teeth too much, you think the vertical's off?
Typically we're infringing on the freeway spaces, which
so can you just talk about that real quick, about how do you what's your go-to to get a vertical, and what's your go-to to avoid that, because that's how, as a dentist, as a 52-year-old dentist, when I'm at the Waffle House and I can figure out the waitress has a denture, the first thing that I come to it is I hear the clacking.
Yeah, and that could be part of it. Howard Payne was my mentor, and I copied his slide that he used to always show, and it was kind of a picture, and the title of it said vertical dimension, an exercise in judgment. And it really is a judgment, because you and I, we would judge it probably slightly differently. And it's just what you, so it's not a pinpoint location, thank God, because we'd probably always be wrong 90% of the time then. But it's a judgment call on an edentulous patient that you try to strive. It's common sense to some degree. I observe the patient. I try to make a judgment based on, a whole host of things. One, let's say they wore dentures. Let's say they've been edentulous for a long time and they haven't wore a replacement. They're going to have a challenge. So I probably, with that type of patient, I'd probably reduce their vertical slightly, because it gives them a little more freeway space, a little more chance to adapt to a prosthesis. Let's say I have an elderly patient that is challenged and has wore dentures for 20 years. Now the denture vertical is significantly wore down. Well, that would be an individual I may not want to try to restore fully, not at one time anyway, back to a more normal vertical for them, because they probably wouldn't be able to tolerate it. So you may have to transitionalize certain individuals. So vertical dimension, it's a process. It's a judgment. It's more of a visualization than I can actually pinpoint to a objective technique of determining it. So it's in the eyes of the beholder. And I sometimes will talk to a group of dentists and I say, don't discount the auxiliary personnel that you have in your office, because they may be better perceptually than you in the ability to look at a person and check their vertical. They're sometimes quite good as an auxiliary to look and...
I want to ask you another question about the teeth specifically, because over the years, it seems like I've read a lot of times that the patients are most happy with 0-degree flat plane teeth. And a lot of dentists with fully adjusted articulators who might have gone to 6 weeks of the Pink Institute and Coist and Spear and all that have talked about 33-degree teeth and 9-point occlusion. And so is 33-degree teeth and 9-point occlusion versus for a dentist thing? Does the patient want 0-degree to like cows? I mean, what's the answer?
Yeah.
What degree inclined teeth do you like?
Well, it's very little science. So if I'd be hard pressed to really point to articles that could really support my particular viewpoint on it. But again, it kind of goes back to some common sense. Edentulalism is such that dentures are resting on soft tissues. So we have to be, unless you're implant supported, but they are relatively unstable. So to put an excessive amount of cusp angle on a tooth and for an edentulous patient is probably doing a disservice, because it's going to cause movement of the denture bases. So a more shallow cusp inclination, I think, is appropriate for edentulous patients, is because their foundations just can't support a steep cusp incline. So 10 degrees, 15 degrees, somewhere in that range, I think is probably an appropriate angulation about to maximize them. But more important than that, or as important as that, is what we call a occlusal scheme referred to as lingualized occlusion. I'm somewhat prejudiced on that because Howard Payne, again, one of my mentors, was one of the founders of that concept of occlusion, but it made sense. It's a very simplified occlusal scheme that's somewhat, I think, universal, where you have a cusp upper tooth, a relatively steep cusp upper tooth, opposing a shallow cusp lower tooth. And there's a lot of good things about that. The upper cusp tooth is going to be more aesthetic, because in your premolar region it's going to have an aesthetic appearance to it. However, on the lower, which is the basis for cusp inclines, the lower cusp being somewhat shallow, it allows for a little easier movement and stability of the denture bases. It's a little more complex than that, because the lower occlusion is relatively uncomplicated. It's not a specific intercuspal relationship. It's more of a trough on the lower, so that, again, it's a little more forgiveness into the occlusal scheme. So it's different than natural dentition. And I think the lingualized occlusion, to me, is the most aesthetic and probably the most functional simplified approach to denture function and aesthetics that we could provide. Flat teeth, as a rule, on a personal note, I think are not aesthetic, especially flat upper teeth. I believe is a real eye catcher to me, and so I'm not a real fan of flat occlusion, nor do I think a patient is. I think it's like two tongue blades coming together trying to penetrate food. Where lingualized occlusion, I think has a better chance of penetrating the food. And also another factor of the lingualized occlusion, it allows the food to escape off the occlusal table, where anatomic teeth tend to trap the food on the occlusal table. So the lingualized occlusion tends to free that up and allow food to fall through the sleuth way, so to speak, because there's no tight intercuspation to trap the food. So again, just kind of a biomechanical feature of lingualized occlusion. It's kind of a universal tone. And another factor with the lingualized occlusion, it supports the upper cheek, because the upper buccal cusp is it's discluded, it's not in contact. It supports the upper cheek and prevents cheek biting. And so that's, I think, a major factor in our edentulous elderly population. They tend to really bite their cheeks quite commonly.
So you're saying lingualized occlusion in 10 to 15 degree?
Yeah.
What if someone said exactly, what would you say?
Well,
lingualized occlusion in what degree?
Well, we do make a tooth that's specifically designed for lingualized occlusion. In the blue line it's called ortholingual, and the Finaris line is called Finaris lingual. And that actually has a 15-degree working side cusp and a actually 20-degree balancing cusp.
Okay, so their names again. Blue line is what? And then Finaris lingual.
Finaris lingual.
And blue line is?
It's the ortholingual.
Do you remember a student named Sam Dominic?
Sam Dominic.
Went to Buffalo?
I don't remember.
You taught him, and in Phoenix, he makes the best dentures I've ever seen. And so I don't know if I should credit Sam Dominic or you.
Well, I should say credit him.
Credit him. So then I want to ask you the next question is, you see techniques where dentists are trying to do a denture in 3 appointments. You see a lot of them teach a technique 5 appointments. To make a good quality blue line Finaris denture, how many appointments should a denture be?
That's the one thing I never trap myself into.
You're trapped right now.
No, I won't let myself.
I'm not going to let you go.
In fact, my standard lecture in removable, I break it down into appointments, but I always explain I do this as a matter of organization to show you kind of what gets done in a clinical appointment, then how it gets transferred to the laboratory. I look at number of appointments. It's almost a personal thing. I was at the VA hospital for a number of years, and I used to enjoy doing what I refer to as an all-day denture. So I'd have a patient and several patients, and we do all the procedures up to the insertion all in that one day. So what is that? Is that a one appointment denture, or is it multiple appointments in a day? I'm not even sure what to call it. So number of appointments is variable according to the clinician and his experience and his ability to treat. I think what's somewhat of a travesty in a sense, in some of the techniques that I've seen more recently put out there, they tend to use a shortcut in a sense, trying to eliminate one of the appointments, and that appointment being the preliminary impression, so that you can make a custom tray and then take final impressions using a custom tray. So they try to shortcut that appointment and let a clinician or suggest that the clinician uses a thermoplastic tray, which is somewhat moldable, and you can get a little bit closer than a stock tray. But I see clinicians struggle with that technique, and I'm really not an advocate of trying to eliminate that particular appointment based on the fact I think it just makes a much longer appointment, and I think the results are compromised. So in the effort to try to eliminate an appointment, I think they've created a monster, and so I think still a traditional technique of of utilizing a custom tray is probably still in the best interest of the clinician to take a better impression. So that's why.
So do you recommend a full set of edentulous trays, or do you use just a custom tray, or
you could get that custom tray a variety of ways. The patient may have an existing denture, which most times they do, and I think duplication of the existing denture is a great way to go.
Explain how do you duplicate an existing denture? My job on a podcast I always feel like is, Dental Town is that no dentist should ever have to practice over again. So probably 5,000 people are going to listen to this, and I just know some dentist is driving to work an hour away, and he's thinking, so I'm trying to guess their questions.
Sure.
So Doc, how do you duplicate a denture?
Two ways to look at it. One is to actually duplicate the denture, and there's these little devices called the Lang, L-A-N-G duplicator. Very simple little hinge device that you could put some alginate in while the patient's in the chair and literally duplicate their denture in alginate, and then pour in some autopolymerized resin and just make a duplicate of their denture.
What resin would you put in?
Just a tray resin, or clear resin. Doesn't just a monomer polymer, mix it up and soup.
So that's made by Lang?
Lang. Mm-hmm.
Where's Lang out of?
I can't say, but it's certainly easy to find on the web.
Is L-A-N-G?
L-A-N-G duplicator, and they also sell the acrylic, the resin.
And then after you duplicate, you fill it up with alginate, you duplicate it, and then you use that for a custom tray?
That could be their custom tray.
And what would you take the impression with as a custom tray?
Again, a variety of, depending on techniques and experiences of the clinician. There could be thermoplastic materials to border mold with, the compounds. People shudder when I say that word, but there's
you still like compound?
I'd like a variation of it. It's called ISO. I believe GM makes it, but it's a compound-like stick. It's thermoplastic, but it's a lot nicer to work with than the
and older, GM makes it.
GC.
GC. I was going to say General Motors. GC.
No,
in Japan. GC. Which stands for General Chemicals.
I believe so.
In Japan and America, it's GCC, General Chemicals Company.
Yeah, but so there's some upgrading in the thermal sticks, but that's probably about the nicest one I've worked with. And then washing, I'm still an old guy, so I still like my old rubber bases. But some of the new innovations with polyvinyl is vastly improved. We have a product called Virtual, which is a polyvinyl impression material, but just recently we somewhat stumbled upon it. We have a Virtual, what's called XD, stands for extra definition. To me, personally, it stands for extra density. I wish we would have named it that, because it does have more density to it, and it stands up and it's more stackable. So it does make a fairly good edentulous impression material. So I've kind of gotten off of my rubber base, and I'm kind of on my XD.
Okay, so now you talked about you definitely want to do a secondary, a custom tray. What would you make the custom tray? Would you make that here, or would you send it to a lab?
That can be done in the office very easily. It's a duplication of the denture, could be done in the laboratory or certainly in the dental office. I didn't complete that story of denture duplication because the other technique that's pretty effective, just did it this morning, took a patient's denture and I filled it with a laboratory putty, Siltec putty, and so then just pulled that out and took their patient's denture, and I took some autopolymerized light pure material, tray material, and made a custom tray. That took me personally a couple of minutes to do that particular procedure, 5 minutes for it to light cure, but as actual physical working time, just a matter of a couple of minutes to make a custom tray based off of the patient's existing denture. So another very simple technique that any dental assistant could be taught, pretty quickly to do. I don't like taking impressions in a patient's existing denture because that old denture is gold. You don't want to modify it, touch it, because God forbid, at the end of the day, sometimes things hit the fan and the patient looks at you, Doc, I know you tried real hard, but just give me my old denture and I want to go on my way. And I don't want to be guilty of touching that old denture. It's still sacred to that particular patient. So duplicating it, I think, is a safer way to go. So one way or the other, complete duplication of denture or duplication of the internal part of the denture to make a custom tray. Two nice, very nice techniques to utilize it. Without that, to get a preliminary impression, then we have irreversible hydrocolloid. The system that I like best to do that type of impression is called Accudent. Accudent's unique because it has a light body and a tray body material. So you could inject a lighter body in the patient's mouth, capturing a lot of the anatomical landmarks, and then the tray material's got more thixotropic quality to it, so it picks up the light body, and it's just a two-phase alginate system. I think is excellent for the edentulous patient in particular to take good preliminary impressions. In lieu of that, we also have thermoplastic trays, which are good, where you could take it and melt or put it in hot water, and you could manipulate them a little bit to get them a little bit closer that fit a particular arch form, and then take a polyvinyl impression, maybe like a monophase polyvinyl material, and to take a preliminary impression that way. Not a final impression, but you can use it to take a reasonably good preliminary impression. I'm partial to a hydrocolloid preliminary impression because it picks up better tissue detail than a polyvinyl can, because it's more hydrophilic. So, but those are different techniques of getting that preliminary impression, make the custom tray, and then proceed to the next appointment. Now, I do want to, maybe this is a good segue, because that's underlooked. You know, taking the impression is the foundation. I mean, without that, we could talk occlusion, we could talk denture-based acrylic, we could talk, you know, the digital denture, we could talk all the wonderful things that's happening in the dentistry. It's all for naught if we don't have at least a reasonably good impression, because digital dentistry is really, it's a computer, and we got to put data into this computer. You know, good data, good denture. You know, garbage in, garbage out if you don't put it. So having you know, some help to the clinician to take better impressions is key. Again, today, this morning, I took impressions using a custom tray that I fabricated. It was a digital custom tray. So I took preliminary impressions, they were scanned, and then on the big screen, I was able to outline, and I could read my muscle attachments. I could read so much better on a big blown up screen of this scan of my impression. I could rotate it in the three-dimensional, unbelievably more accurate. And I made an outline for custom trays. And I tried my custom tray in this morning, and they were exquisite. They were better than I could ever do, you know, by hand manipulation. So I look at that as an advancement in dentistry, using the digital technology.
When you got out of prosthodontic school 40 years ago, did you ever think you'd be doing that?
No.
40 years ago?
Never in a million years. Never in a million years. I even with the fixed area, I experienced it all, and I saw the early fix was, you know, a crown that fit like a sock on a rooster. And I never thought that would ever get improved and actually become the standard.
So I'm going to hold you down for details. Talk exactly what you were doing on this digital dentistry. What were you scanning it with? Where were you sending it? I'm in Phoenix, Arizona. There's a lab up the street from me. Was it Vivadent?
Vivadent.
Vivadent. So when we got out of school, there was no digital denture. Talk about digital denture, but name specifics. Who's doing this? What technology?
Okay. There's, I mean, digital dentistry has touched almost all phases of dentistry, and removable is really the last vestige that really hasn't been utilizing the digital process. Vivadent is a company that was, I'm not sure how many years they've been in existence, but they've explored digital dentistry for removable, and it made some very good inroads in that particular technology. Their process is, and I won't speak for them, but what I understand, it's more of a centralized service where the dentist deals primarily directly with the center to have a denture fabricated. The Ivoclar Vivadent recently announced that we're in the digital denture arena as well. Our business mode of operation is typically through dental laboratories, and we pride ourselves in systems. So we're introducing a digital denture system for dental laboratories. So the dental laboratory would have the capability of doing all the procedures, from scanning to the computer design to the computer fabrication of making the denture in the individual dental laboratories, which I think personally has a lot of merit, because the technician is a terrific partner to the dentist, and especially in removable, because there's so much subjectivity in removable that it's nice to have a good technical partner to help guide through that process. And by virtually eliminating that technical involvement, I think was probably not the way I would want to go. I'd want to include the technician as our partner. And so this system is particularly designed for
So
that.
you were optically scanning it with what?
So I take an impression, and it could be an impression from a duplicate denture, could be an impression, could be whatever preliminary technique you would employ. Then that is going to be scanned we use a 3-shape scanner.
And who makes 3-shape? 3-shape.
3-shape.
And where are they out of?
I believe Michigan, but I'm not really familiar with their. I know we sell 3-shape scanners as part of the package, but I'm not exactly sure where they're.
As part of the package with your denture miller?
With this system.
Is it CAD-CAM?
Mm-hmm.
And what's
the whole
name of
CAD-CAM process?
Search the W?
The Vivadent is the center that we
With a
use.
V or W?
W.
Yeah.
Vivadent. And there's
Say again?
Vivadent.
But it's spelled a W.
But it's spelled
you
with a
pronounce it with a
W.
V?
Right.
So, okay, so that's why I'm confused. So
Yeah.
it's spelled with a W and pronounced with a V.
Right.
Vivadent?
Vivadent. I guess
So,
it's a
so what is that?
pronunciation.
Is it a German
It's a
pronunciation?
German pronunciation.
Do
And-
Germans pronounce most W's like a V?
Yes.
Really?
Yeah.
Okay.
Yeah, that's as far as I understand. I'm a little better in Italian than I am German. But Vivadent is the sister company with Ivoclar in this digital denture process. So we've teamed together the two companies to Vivadent is owned by Ivoclar, but it's a kind of a separate company with the milling machines and things, but they've kind of supported this operation to develop a system, the digital denture system. So the design and the milling is Vivadent, and 3-shape, again, not a part of our company, but we incorporate their scanning process so that we can really complete off the system. The design software obviously is Ivoclar, and that's an add-on software to the 3-shape, and that all that part I don't. You have a lot of detailed information.
Now, what else? Now, you can use a 3-shape for Crown and Bridge too.
Sure.
Yeah.
It's a scanner.
So
It's a software upgrade that makes it unique to removable.
I thought the neatest thing about the milling, though, for myself is I just assumed if you were milling a denture that all that acrylic would just gum up in the burr. But they were actually able to figure out a way.
Yeah.
What, they ionized it or something so it wouldn't gum up?
The actual milling machine unit that complements this is it's the Select mill that we use for Crown and Bridge, but it has what's called an ion. It's the Select ion, and quite ingeniously, it reduces the charge of the particles and collects it. It is dramatic, the difference with the machine with it and the machine without it.
Otherwise it's
And
snowing, snowing in there, right?
It's not only dentures. We do an awful lot of milling for temporary Crown and Bridge. So any polymethyl, any resin-based material, the ion machine is excellent for. So this is, I think, a real advancement in getting into the.
I want to switch gears, or did you still want to do the steps of your finish the steps of your denture?
Okay, so just what I just did. Took preliminary impressions. We scanned it. And then after it's scanned, it takes a couple minutes to scan, and then it's up on the screen. And if the clinician has the access to the software upgrade, which I think most clinicians are going to be having a scanner in their office. I think that you've seen that growing pretty immensely. This could be
Because of CERAC, because that
Right.
scanner, you mean?
Right.
So that's probably the most common scanner.
I think that's probably the most common, but I think having a scanner in the office is going to be commonplace.
So you would agree that the most common scanner is probably CERAC, because, I mean, Cerrone, because they got 13,
Right.
14,000.
That's intraoral scanning, but I'm saying extraoral scanning.
Extraoral?
Well, extraoral meaning to scan an impression.
Well, can you scan that with a CERAC scanner?
It would be much too time consuming.
Okay.
You know, because you have to take.
So you need
many
an extra
pictures.
oral scanner.
Right.
And what would be the most,
three
the three shape, was that the most common?
It is.
What would are there any other ones that?
There are, and I'm not familiar with all
Okay,
the
so-
different names, but there's a
So
host
three shape
of,
is the market leader in that, probably.
There's
Okay.
scanners where you could scan the entire impression
Okay.
in one shot, and it's rather than taking 1,000 little pictures of the
Mm-hmm.
impression. So that type of scanner, I think, will be more and more commonplace in dental offices because it allows the clinician to scan their impression very easily. And not take the risk of sending that impression to a laboratory to be poured or to be scanned, and I think then it's an electronic file that could then be sent to the laboratory for the.
I cringe in Phoenix
prosthesis.
where for 6 months of the year it's 100 to 110, and you take
Yep.
an impression, you put it in a box, they throw it in the back of the UPS truck, and
Yep.
you could see on TV that they were saying, well, the inside of the back of a UPS truck is 140 degrees because of the heat they
Howard,
have.
I just opened up a new box of my ISO compound material, and it was all melted.
Yeah.
So somewhere's in transit, it hit some high temperatures, so you don't have any control on
And what do you
that.
think of the World Cup next year is going to be in Qatar?
Oh, I think it's ideal.
120 degrees. What great place to have a soccer game. 120 degrees.
I can't even imagine being a spectator, much less a player in that. But again, the scanning process, what it does, it opens up a complete different world in removable, because what I was then able to do as a clinician is, with a reasonable knowledge base of anatomy, knowing how to outline my custom tray makes all the difference in the quality of the next impression. And so when I tried my digitalized milled the denture bases, which could also be printed, by the way, printed or milled, it's done to design and read beyond what you would do in conventional terms. So your impression tray, with a reasonable preliminary impression, boy, you're light years ahead on my next clinical appointment, which is to take a final impression, which is the foundation of everything from that point forward. The only point I wanted to make with that is digitalization is not only, we think of digital dentures, well, mills, and it's the machine. And it does a marvelous job of milling and putting the teeth in. It's like a miracle in itself, that part of it. But I'm a clinician. How does it help me? What's in it for me? How do I provide better care to my patient, more efficient, more productive? And so the clinician's got to ask that question. It's nice, it's really fun to watch this mill and all that, but clinically, I don't care what you do over there. What is it to help me on this end? And that's why I'm most interested in the clinical applications where digital dentistry could help me clinically. It goes beyond just a preliminary impression. We got devices and methods to mill in custom rims on the denture base instead of the traditional rims. These are custom rims. They could also be fitted with very precise tracing devices. So it's not a pre-manufactured, not so quality-oriented tracing devices. These are pinpoint, incredibly stable devices that we could mill into our rims. That's helping me clinically. I did a jaw record again this morning on my patient, and I complimented the fact that I did an intraoral tracing in probably 10 seconds. and if not less, and I got a pinpoint, very, very accurate tracing because my bases were so stable and the devices that I clamped in were really incredible. Now that helped me. That was digital dentistry helping me clinically capture what I think is a very challenging appointment, a centric relation jaw record. So it helped me. So I achieved benefit from the digital process today in being able to do better dentistry for my patient, more efficient, and so I'm excited. Now, I will say this as well. Digital dentistry is hit removable. There's no going back. It's here to stay. It's going to get better, more innovative, more. It'll change the world in which we've known removable prosthodontics for the better, and it's just going to be kind of exciting to see how everything's on the table. It's just going to grow in the innovation part of it. So that part I'm pleased to see that I'm still here, still involved in dentistry, where I could help maybe even shape that process and contribute to it at the very least. And for that part, I couldn't be more excited. Couldn't be more excited.
Okay, you're a grandpa.
I sure am.
So am I. So what would you say if one of the people listening to this podcast is a junior or senior in dental school, and they're saying, should I be, you're a prosthodontist, it's one of the 9 recognized specialties of the American Dental Association. There's some kid listening to this right now saying, should I just go out and join dentistry, or should I go and become a prosthodontist? What would you tell that person?
Well, I guess on a personal note, I can't imagine not specializing personally in prosthodontics. It's been my hobby. It's part of my life, and I certainly made the right choice for myself as an individual. Why I made it, I think, I just so loved the challenge of the diagnostic part of dentistry. And I was exposed, fortunately, to a couple of good prosthodontists who I was always admired their ability to quarterback the big treatments and to really kind of see, understand the perio, the endo, that it kind of quarterback the entire treatment. So I think if that's, as opposed to, I guess, an endodontist who's kind of tunnel visioned into what they have to be into that type of work, and I kind of like the bigger picture, the larger restorative, the more challenges on that end of it. And that's what makes you excited and kind of thrilled. I think prosthodontics is perhaps especially if you want to know why, the answers behind. I did a face bow record. Why did I do a face bow? What did it do for me? What's the science behind it? If you have that kind of, I guess, curiosity, then that specialty is kind of the natural area for you to maybe achieve. Now, a lot of things have gone on in prosthodontics that has been, with implant dentistry and aesthetic dentistry. That's kind of the foundation of prosthodontics. So if you wanted to really learn more about that and to have a higher level of achievement in those areas on the restorative side, then I think prosthodontics is a great specialty. In high demand, by the way, in high demand at this particular time. Would you say high demand if you don't surgically place the implants? Because I see prosthodontists who say, well, I started placing the implants and now I don't get any referrals from periodontists and oral surgeons. And then other ones say, okay, be a prosthodontist, but don't place the implants, so you get all these referrals from periodontists. And so if some kid was going into prost school, would you say learn to place implants or not? Yes. In fact, it's incumbent upon the prosthodontic program to develop some reasonable level of competence in surgical placement. Now, when you take that information and that knowledge base and go into a private practice, I think you have to certainly analyze your environment and referral base and et cetera. If you were in a particular community where you're the one to place the implants because of that particular community, then you have the capability of certainly within your comfort level to place implants. If you don't place implants, I think you're in a better position to guide the process through another party. So you'd be able to understand if you don't to have the competence to know how to place them, then try to communicate that, I think is going to give you an edge in providing the right stents and information necessary to the surgeon then to place the implants.
I've only got you for 10 more minutes. This has been the fastest interview I've ever done. The reality is that 94 to 96 times out of 100 a crown is done. It's done 1 unit at a time, okay? And a lot of dentists are thinking, is it okay to do a sideless, Premier triple tray for a single unit if I'm using a lab, which is still the majority. I mean, Sarasota is probably only in maybe 10, 12, 13% offices. So is like a sideless Premier triple tray okay? Should it be a metal tray? And then where do you cross the line to where you say, no, I'm a prosthodontist, you need full arch impressions? And then where do you cross the line to say, I need a Facebook transfer?
Yeah.
Answer those three.
Oh gosh, all individual type questions based on the clinical event at that particular time. Obviously triple trays done correctly. In other words, if you have a triple tray, hopefully that you use one that's rigid, because one of the two dangers with trays like that could be abused. One is obviously if it's flexible and you have the patient close down into it, and then when they release, if it's flexible, it's going to distort, and so it could look perfectly fine.
So what's your favorite quadrant tray? Metal or disposable plastic?
Metal, at least, or rigidly plastic design.
You prefer the metal just because it's rigid? But then some people say, well, if it's a metal tray to bite in there, their bite will change.
And then obviously you have to be cautious. The second part of that answer to that question is that you don't want to interfere with the occlusion. So you've got to make sure its placement clears where the occlusion is going to be. So rigidity, base it on rigidity, and base it on make sure that you don't interfere with the occlusion. Those are the two factors. And certainly the third factor, I guess, would be don't exceed its expectations. For single units, one thing. Going into 2 or 3 units, I question whether you'd want to use that type of tray system.
Well, come on, 40 years, prosthodontist, grandpa, just tell them. 2 units,
use a custom tray, or at least a full arch tray. Sure.
Okay, but your Freudian slip was custom tray.
Yeah. No.
Do you prefer a custom tray
No, I
for
don't.
2 units?
No, I don't.
Okay.
No, I'm thinking removable. But at least a full arch tray.
So you say 1 unit you can do a tray. You like it to be rigid, not too rigid to where it doesn't interfere with their bite. You got to make sure they can bite.
Right.
But if it's a flimsy plastic tray, and when they bite down, they distort that tray, and they open back up, it's going to distort back. There goes your impression. So, and then you're saying full arch tray for 2 units more.
Anything more than that.
Anything more than that. And what about Facebo?
Facebo is, to me, somewhat controversial. We have what I think are better systems that I think gather more easily gather probably more accurate practical information that we need. What does a Facebo do? If I could throw the definition, it's a Galper-like device that captures the glenomaxillary relationship in 3 planes. I could throw all that out. Well, what does that mean clinically? Well, it means basically that you're capturing the upper jaw in relationship to kind of where we think the jaw spins, open and closes. So we're kind of capturing that distance, that opening and closing axis, and putting it on the articulator. Well, how important is that? Well, it's somewhat important, but can we do the same with an average value method of mounting? Probably. In other words, we're not that different. There's a relatively close average. Dr. Coyce has done some research on that, and I think his figures around 104 millimeters is pretty darn close to average. And that average doesn't
104 millimeters from
the spin point, the hinge axis point, to the incisal edges. To that approximately distance doesn't vary a whole lot. So like 90% of us fall within this
104
millimeter range, at least 100 millimeters to 105 millimeters, somewhere in that range. So So probably a average value system could work very well and maybe even do more for us, because the more important, when it comes to the clinical aspect, most important is the patient's aesthetic plane, and transfer that to the instrumentation so that the prosthesis, when it comes back, is in aesthetic harmony and not cockeyed. And so I think that's probably as important, if not more important, of this transfer. And we got wonderful transferring devices. I just did one this morning, again, with our digital dentures. We have a device that very, very accurately records the patient's aesthetic plane, and also the occlusal plane, what we call Camper's plane, in the sagittal view, but it's so much easier than a traditional face bow, and I think much more accurate. So I think there's other techniques in Coyce. John Coyce has got his Coyce analyzer, which does similar. It's kind of like the stick bite, glorified stick bite technique, where you could transfer that information. And I truly do think that's more important, more valid information than the opening and closing axis, which could be also, guesstimated with a good average mounting system. So I think within clinical acceptability. So I'm thinking there's other devices that are probably going to be replacing face bows, and that's just my personal speculation.
So is Coyce is John Coyce in Seattle not using face bows?
Right.
He's not using.
No, you can use this with that analyzer.
Can you? I've looked at your performance. Can you explain the Coyce analyzer? I mean, he's a legend. Can you go into a little more detail about that? Where's my timer?
Yeah, one of the we have. I think John's selling his through Vivadent.
Panadent? But what's Panadent?
An articulator system. I think that's what.
Panadent, PANADENT.com.
Right. And but we also have an articulator called the Stratus articulator. Ivoclar does, and the Stratus or the Panadent both have devices that accept the Coyce analyzer. So we have a little table that fits onto our articulator that then accepts the transfer of that registration that you would use the Coyce analyzer. And really, it's, as I said, it's kind of a box plane, kind of a glorified box plane, where you have a little white registration material that's added to it, and you kind of level it to where you think is a good aesthetic plane of the patient, and then that information is transferred to the articulator so that the articulator will mount the cast so that the occlusal plane or the bipupillary line is parallel to the tabletop. So when the technician fabricates the restoration, it goes back in an acceptable, aesthetically acceptable plane.
One of the problems I believe about removable dentures and all that stuff is if I do 2 or 3 crowns a day and I do 5 or 6 fillings a day, I just get really good at it because I do it every day. But if you only do a denture once a month, it's sometimes hard to reach critical mass. I've always wished I'm throwing you under a bus right now because you're live on TV. I've always wished you would do an online curriculum on Dental Town. Because the online CE is, it's, University of Phoenix Online. Mm-hmm. The reason our online CE just passed 500,000 views. Wow. And the reason is because a lot of times in these economies, they say, I don't want to close down my office for a day. And I also, that might cost them $4,000. And then on the CE, it's a lot easier to listen to it in hour segments instead of signing up to listen to 8 hours to work 3 o'clock in the afternoon, you're falling asleep. Yeah, sure. But would you ever be up for, as you're live on TV to on podcast?
How could I say no to you, Howard?
I would love it because what you do, you make it sound so easy, but it's hard for a lot of reasons. And the biggest reason is you only do 1 a month. Yeah. And the second reason is this is all you've done for 4 decades, and a lot of these kids are just, they've been out under 5-10 years. I would love to have a curriculum.
I appreciate that so much, and I think the innovations that are coming forward with the digitalization is making that easier to teach, easier to practice, easier for the clinician. So I'm all about that. Removable is such a incredibly challenging, subjective procedure. The more we can kind of objectively define it and help with the help of this digitalization process, I think it's going to help clinicians who, as you said, they're not going to do these every day. But if they have a nice package of armamentarium that's relatively simple to understand, easy to apply, and then using the digitalization process to help them guide through it more easily, they'll enjoy it more. They'll get better, more success, and everyone enjoys success. So.
Yes, and I can't believe we're out of time. It's been an hour, and I think the big takeaway is that digital dentures are here, and they're it's not going to go away.
No.
The genie's out of the bottle.
It's out of the bottle. It's going to.
And if 5,000 people listen to you, someday they'll log on to Dental Town, and you'll show them how to do this online.
My pleasure.
It'd be an honor.
Pleasure.
Hey, thank you, seriously. On behalf of all your students you educate at Buffalo, leading this for 40 years, really. And you're an amazing man, and you're a legend in my eyes. And thank you so much for an hour with me.
Thank you.